we do not have to.
Apurva sir, you can go ahead.
Yeah.
You're live.
A very warm welcome to the 6th World Congress of Cochlear Implants in Emerging Nations under the aegis of Global Cochlear Implant Access Network and the 8th National Conference of the Cochlear Implant Group of India, the CIGICON 2021. It's so fantastic to have such eminent professionals from various geographical locations and for them to accept to become available even though at different time zones for this World Cafe. The concept of this World Cafe started from Dr. Fatih Baki during the last edition, that is the 5th edition of the World Congress of Cochlear Implants in Emerging Nations in Cairo, Egypt, where the purpose of this World Cafe was to try and look at the current and evolving topic and to have the experts from the field to try and make guidelines for the assessment, diagnosis, management, and also look at various challenges and the controversies that can arise. This session is been allocated around 2 hours to try and deliberate and discuss. And this is going to be a closed door meeting for now, but the proceedings are going to be recorded and later is going to be made available on the website link as part of the conference proceedings. And with that introduction to the World Cafe, I think it's now time for me to introduce the moderator. So it brings me.
Just a minute.
Yeah, Satish. Thank you. So it's a great pleasure for me to introduce Ms. Nivita Narayan. She's been a dear friend for more than 2 decades. And Nivita needs no introduction, and she's a very popular face in South Asia. She did her speech and hearing qualification from the AIMS Institute, New Delhi. She also holds a master's degree in business administration. She got her training in cochlear implant and or brainstem implantation from the UK, Melbourne and Sydney. And she has also worked as a clinical audiologist for Widex and also been a clinical specialist with Cochlear for 8 years or so. Altogether, she has over 24 years of experience in the field of cochlear implants and helping children. She has been actively involved in the field in giving various presentations across different conferences and won various awards. She's also been invited on various conferences, both national and international, as a guest or an invited faculty. She is a member of ISHA and also the Cochlear Implant Group of India and has served a term as a EC member for the CG as well. Currently, she holds the position of the Chief Audiologist and the Director of Spear Speech and Hearing Clinic, New Delhi. She is the Implant Specialist Audiologist at Apollo Hospitals, New Delhi, and also holds the position of Secretary and Treasurer for the I Can Hear Foundation. With this, I welcome Nivita, and the virtual stage is yours for this World Cafe session on EAS. Take over.
Thank you, Apurva. It's a complete honor and privilege for me to moderate this session and also learn from real experts in the field. And it's a real honor for me. Thank you. I would like to thank the OC to give me this privilege. And I would like to introduce all our panelists who are really esteemed dignitaries in their own ways in this field. So Satish, will you please share your screen? Next. So I welcome Dr. Susan Walsman. Dr. Susan Walsman is America F. Willig Professor of Otolaryngology and co-director of the NYU Cochlear Implant Center. Research focus on 2 main areas: outcomes with cochlear and brainstem implants and isolating the variables with effect performance, including the impact of new technology on outcomes in children, adolescents, older adults, and special populations. Current research at the Cochlear Implant Center focuses on the treatment of those with single-sided deafness, residual hearing, and children with compromised auditory nerves. PI on numerous device-related clinical trials over the past 20 years, the most current trial being the use of auditory brainstem implants in children with compromised auditory nerves. Author of more than 110 peer-reviewed articles, numerous book chapters. In 2014, the third edition of the textbook, the Dr. J. Thomas Ronald, titled Cochlear Implants. Visiting professor at many institutions worldwide and is a frequent contributor and invited speaker at national and international conferences. Welcome, Dr. Susan.
Thank you.
We have with us Dr. Mario Zanotti. I hope he joins soon. He's from Argentina. He's a professor of ENT at Catholic University of Cordoba. He's a professor of ENT at National University of Villa Maria, professor of otology at National University of Cordoba, head of department otolaryngology at Sanatorio Allende, current working on project titled Cochlear Implantation in Single-Sided Deafness, leader in the project Audiological Outcomes in Microtia and Atresia Patient. Welcome, Professor Ma.
Thank you very much for the invitation. The pleasure is mine.
Satish. We have with us Dr. Arthur Lawrence. He's a known face, and we have met him so many times here. So he is from Warsaw, the Department of Auditory Implants and Perception at the University of Physiology and Pathology of Hearing, Warsaw. Professor Arthur Lawrence is the head of the Implants and Auditory Perception Department in the Institute of Physiology and Pathology of Hearing, Warsaw. His scientific interests focus in the field of application of cochlear implant systems, psychoacoustics, and auditory perception modeling. Member of the Polish Scientific Association of the Hearing and Communication Disorders, the American Auditory Society, the International Society of Audiology, the European Society of Artificial Organs, the European Academy of Otology and Neurotology, scientist in charge of the Hearing Treat Marie Curie U project, main executor of 5 projects of the Polish State Committee for Scientific Research. Welcome, Dr. Arthur.
Thank you for invitation.
We have with us Dr. Ranjit Rajeshwaran. He's a dear friend and well-accomplished audiologist in his own way. He holds a position of professor of audiology and director at Murph Institute of Speech and Hearing. He's a chief audiologist of Madras ENT Research Foundation, Chennai, India. He's a director of Hearing for Life Foundation. He's a president, Indian Speech and Hearing Association, Tamil Nadu chapter. He's a vice president for Cochlear Implant Group of India. His experience of 23 years in implant audiology. His area of interest is auditory neuroscience. He's been awarded as Best Teacher Award in the Tamil Nadu Dr. MGR Medical University, the Distinguished Alumni by Sri Ramachandra University. His PhD thesis is Application of Auditory Evoked Potential in Auditory Brainstem Implant. He has a membership, he's a founder member of Cochlear Implant Group of India, he's a founder member of Hearing Group, and he's a member of Indian Speech and Hearing Association. He initiated Cochlear the first auditory implant program in 2004, postgraduate diploma in auditory rehabilitation at RCI, the cochlear implants in Sri Lanka and Nigeria. Hence, he has a committee, Rehabilitation Council of India, member of Board of Studies, Tamil Nadu, Dr. MGR Medical University, Salam College of Engineering, and has guided 57 postgraduate thesis published articles. Welcome, Ranjit. It has been an honor to read your bio, really. I knew
Thank
you
you,
differently. Welcome, Ranjit.
Thank you.
Can I have Satish? Can I move the slides? Satish, can you please move the slide?
Sir, I've moved it.
I can't see it on my screen. Dr. Professor Mohan Kameshwaran, I have a different regard for you, sir. And it's an honor for me to invite you here. He's a senior consultant and managing director of Madras ENT Research Foundation and honorary distinguished professor, Tamil Nadu, Dr. MGR Medical University. He's a Padma Shri awardee 2006, Dr. B.C. Roy Award in 2008, and pioneering cochlear implant surgeon in India and South Asia with personal series of nearly 4,000 cochlear implants. The first auditory brain and has a personal series of over 50 auditory brainstem implants, has over 200 publications in major national international journals, and has attended and presented papers in almost 450 national and international conferences, and has been an invited lecturer in several of them. He has conducted and attended over 325 workshops on temporal bone surgery, skull-based surgery, live laser surgery, and audiology for surgeons, and many more. He has achieved Australian Awards 2006, National Award of Excellence in Sri Lanka 2007, Doctor of Science on honorary basis, the Tamil Nadu MGR University Medical University. He's a visiting professor of Edge Hill University, UK, honorary professor, Department of ENT, SRM College, Medical College, Hospitals and Research Center, Chennai. Member and Executive Council, National Academy of Medical Science, India. Welcome, sir. It's an honor to have you with us here. We have with us Professor Dr. Thomas Lennars. He's from Germany. Professor Thomas Lennars is a renowned expert in the field of otolaryngology and surgery in the head and neck. Built the department's position as global leader in cochlear implantation, implantation in children, refinement of surgical techniques, and enhancement of products realized here have resulted in significant advances in worldwide. Scientific work supported by the Collaborative Research Center on Biomedical Engineering, funded by the German Research Association. Research outcomes are transformed into advances in modern auditory implants in close collaboration with manufacturers. He has 620 research papers with over 7,500 citations. Welcome, Professor Lennars. It's a real honor to have you with us. So I welcome all of you, a very warm welcome, all the panelists with us. It will be a great learning experience for me personally, and I'm sure for everyone. I invite each one of you to start your presentation. And each presentation I had requested for 10 minutes because we have limited panelists on this panel. And then after your presentation, I will be asking and discussing questions on this topic. So may I invite Dr. Mohan Kameshwaran to start with his talk, sir.
Thank you, Nivita. Thank you very much. Can you hear me?
Yes, sir.
Okay, right. So, in the early 80s, when we actually started cochlear implantation, in the 80s and 90s, we had the impression that electrical hearing was distinct from acoustic hearing. And most of us had this impression. In fact, we were actually, deluded into thinking that these two were incompatible. And in fact, very often, even I have personally told patients that, if you have electrical hearing, it's not going to be compatible with acoustic hearing. And all this has changed, of course, that today we know that you have the concept today of combining electrical and acoustic hearing in the same ear. And this has led to the concept of electroacoustic, or what we call hybrid hearing. Now, of course, most of the things, are going to be rehashing the stuff which all of us know, but nevertheless, maybe a good idea to recapitulate some of the concepts, where you have in the lower frequencies, hearing, which is acoustic, which can be beneficial to the patient. You can, either it's in the normal range or is a moderate or severe hearing loss, which can be amplified. And then you have in the mid and high frequencies, profound hearing loss. So these patients very seldom benefit from hearing aid usage. They usually are quite uncomfortable or unhappy when fitted as a hearing aid. And the reason being that the mid and high frequencies where there's profound hearing loss are not benefited at all with conventional hearing aids. Acoustic hearing, between 125 to 1500 hertz, where you can still use amplification and electrical hearing through mid and high frequencies. The sounds are received by a single microphone in order to avoid directional interference. And high and low frequencies are processed independently from one another, preserving the synergistic effect between electrical and acoustics. In other words, there is parallel signal processing. So what are the indications? It was a mild to moderate hearing loss in the low frequencies, up to 1 kilohertz, and then it's going on to severe to profound hearing loss. The frequencies of 500 hertz and below are crucial for maintaining the acoustic part of the hearing, and this maintenance of this acoustic part does a whole lot of good when we are looking at the patient's overall benefit in picking up signal from noisy environments, as well as things like music appreciation and so on. So the indications all of us know, I think I'm sure we're going to be talking about it. So maximum aided speech understanding of monosyllable should be 60% or lower at 65 dB in the best aided condition, and the maximum airborne gap of 15 dB, not more. So classically, that's the kind of audiogram that we are talking about, but we must exclude progressive hearing loss. In my own practice, I insist that at least 2 audiograms 6 months apart show no change in the hearing status. In other words, the hearing has to be stable. Hearing loss also has to be stable, which automatically excludes a whole lot of diseases like autoimmune disease, meningitis, where you can have progressive loss, autosclerosis, and so on and so forth, and cochlear malformation. The usual preoperative investigations, a whole battery of audiological tests and vestibular testing as well is very important in these patients, and imaging. The factors which determine success are the single most important prerequisite is in following the surgical principles of hearing preservation. And we need to counsel, even though you may have fairly good results, you still have to counsel the patient about the risk of losing residual hearing. Even though the risk may be small, it has to be clearly enunciated to the patient, and the patient has to be aware of this risk. The 1000 hertz region to me is the most important region, and it defines the end of the electric and the beginning of the acoustic stimulation. So electrodes have to be specially designed, soft electrodes, which are atraumatic, and insertion has to be in a very specific way, very deliberate, slow, and soft. The factors which can cause damage to the residual hearing are the acoustic trauma generated by drilling, and then the mechanical damage of the very fine structures, intracochlear structures like this osseous spiral lamina, the basilar membrane, and tearing of the endosteum of the scala tympani, and also the disturbance of cochlear fluid homeostasis. As we insert a piece of metal into the hydrostatic pressure inside the cochlea goes up, and we have to compensate for that by allowing time for the increase of fluid, so that the very delicate fluid homeostasis inside the cochlea is not disturbed. Of course, inflammatory response and fibrosis infection. So specific surgical considerations, soft surgical techniques, as Thomas had mentioned in the early 90s, to lessen the acoustic and mechanical trauma. Round window, generally preferred by most of us. In this we followed the original paper from Henrik Skazinski and group, which Arthur represents. There are people who also have soft cochleostomy techniques which can be used, particularly the group from Iowa, Bruce Gans and group have used it quite successfully. But the important thing is to do the procedure with reduced risk of infection and inflammation. Generally, steroids are used intraoperatively. Our own center, we prefer to use IV methylprednisolone, one which we started immediately about half an hour before the actual insertion, along with IV antibiotics. But there are also people who do the insertion in the operative field filled with steroid liquid. So we can either do, as I said, cochliostomy or round window. They both have their proponents and opponents. We'll probably talk about it later. But our own preference is to use the round window insertion techniques. So the important surgical concepts are to identify the endosteum and opening it with a very fine pick or Rosen's needle if you're doing a cochliostomy. In the round window, also a very small round window myringotomy, as you said, in the anteroinferior quadrant, with no suctioning of the perilymph, very, very minimal dramatic insertion, which means you have to take your time for the insertion. Generally speaking, we advocate at least 2 minutes for the entire insertion process. It means you have to go electrode by electrode very, very slowly and very specially designed ultra thin flexible electrodes. So as I said, slow insertion and advance the electrode in the anteroinferior direction away from the lateral wall of the scalp. Insertion depth should be controlled to 360 degrees for one full turn, and cochliostomy sealed immediately with soft tissue. Okay, so the advantages, of course, the low frequencies provide additional information for speech perception, speech production, and environmental sound awareness, and superior place code, that was temporal code, compared to classical CI coding, probably more or less close to normal. So therefore, this leads to better speech recognition in quiet and in noise and multi-talker backgrounds due to better preserved hair cells and spiral ganglion cells, and improved speech perception noise by at least about 9 to 10 decibels. Which actually compares to about 30 to 40% improvement in hint sentence scores, and more significantly enhanced cue music perception. So I think to conclude, it has enabled sound perception, the entire speech spectrum, and we need to do it. Now, our own series is about, we have looked at it out of this 4,000 we have done, about 11 cases actually. They're not very common, but about 11 cases typically. And we have been able to preserve hearing within 10 decibels in 10 out of 11. In one, there was about a 30 dB drop after the surgery. So roughly translates to about a 90% possibility of hearing preservation within the first year. And then in the long-term follow-up, most studies have shown that there is a gradual tendency to drop off in about 3 years to 5 years. So long-term follow-up may show an additional 10 to 15%. Showing progressive drop in hearing. So that would be more or less the experience from different centers in the world. Thank you.
Thank you, sir. Thanks for the lovely presentation. May I invite Dr. Susan Walsman for her talk?
Okay, thank you. Okay, can you see the screen and hear me?
Yes.
Great. Okay, so I'm going to just address some of the issues that come with EAS hearing. So it started, the timeline basically is that it's possible to save residual hearing. And this prompted the design and study of various electrode lengths. Short electrodes did show some kind of advantage, but performance with short electrode drops if the acoustic hearing is lost. And we've seen that from a number of publications, which means that these patients would have to be reimplanted, a lot of them. Recently, standard electrode length electrodes have demonstrated hearing preservation capabilities, and this has enhanced the possibilities here for us. So our focus has shifted from looking just at the shorter electrodes to looking at all electrodes and seeing what they can do. Oops. So what we need to do now is take a closer look at patients who meet hybrid criteria. We need to look at EAS use and the impact on outcomes. And we need to investigate the quality of this residual acoustic hearing. We shouldn't just assume because it's there, it's worthwhile. So where are we going here? How is residual hearing useful? What amount do you need to see the benefit? And how can we predict who will benefit from it? And how do you choose an array for these patients? So the surgeon wants a marker of atraumatic insertion and structural preservation. The audiologist would like to see better speech perception, and the patient wants to see more benefit in complex listening situation. So the EAS system, as we just heard, is designed for patients with a ski slope pattern of hearing loss. Initially, the shorter electrodes were designed to stay completely within the basal turn to avoid trauma to the apical regions and the low frequencies. Soft surgery is one way of reducing intracochlear fibrosis and ossification. And in addition, the new electrode designs are thinner and more flexible, and all manufacturers seem to have that. So I just decided to look at number where we have a very large N here. We did a very large study. And so we're going to look at just the 532 for now. And we could see the pre-op less than 75 dB, there was residual hearing in 100% of the patients. But if you look at initial activation, 3 months and 12 months, there is a steady decrease in the amount of residual hearing. So let's look at some examples. Here's a 75-year-old female, left ear, 48% CNC words pre-op. And this should be at the initial activation, her hearing had dropped a little bit. At 3 months, it was pretty stable. At 12 months, dropped a little bit more, but not so much. She did not like the EAS configuration at all. And she was much happier with the electrical component. And also she wanted to use the Canzo. She does very well, electric only, 76% CNC at 1 year. The second example is a 48-year-old patient, pre-op 32% CNC. Didn't feel that there was any additional benefit to using the acoustic component. And felt that sound quality was better with the all electric program. And again, she prefers to wear the Canzo. And she had very good CNC word discrimination at 6 months. The third example, 69-year-old female, 0% CNC pre-op. She initially was fit with the acoustic component at initial activation. She did do better at 3 months with the acoustic component, and she does wear it. She gets 58% electric only, but 70% using both. Now, here is a 61-year-old female, 32% pre-op. She was fit with the acoustic component at initial activation, did very well with both, 76% at 3 months. Then she went to hear a Jimmy Buffett concert a month later, and she lost all of her hearing no recovery with steroids. She uses electric only, and she gets 80% discrimination on that. So what do patients want? Well, here is a perfect example that we can't make any judgments. On the patient on the left who loves EAS, technically should not like EAS at all, does not have the thresholds for EAS. The patient on the right for whom EAS was designed totally rejects EAS and uses an electrical component and does very well. So we looked at 500 plus patients implanted with the 532 and 632, 95 patients with 3-month post-op data, 51 have data through 1 year. And now we're moving beyond retrospective data collection to prospective work. So inclusion criteria for this was they had to have at least 3 months CI experience, low frequencies of 75 dB HL or less, standard length electrode. We did not use any shorter electrodes in this. And here is the reasons for non-use for the EAS configuration. One, if there were borderline thresholds. In other words, they were very close to that 75 dB mark, and they just didn't feel that it benefited them. The other big thing, and this is getting to be a larger population, they like the off-the-ear processor, and they don't want to have all this other equipment on them. So overall hearing preservation rates are estimated now to be about 50 to 60%. The superior long-term performance provided by greater frequency coverage using longer electrodes as opposed to a hybrid-like electrode may be preferable, given that patients who have lost their hearing appear to perform better in electric-only condition with longer electrodes, meaning they won't need a new surgery. So we find that using the longer electrode is wise. I think here in the US, I don't know of anybody who really still uses the hybrid device. So ongoing studies, we see not all patients benefit despite preserved audiometric thresholds. And even when the hearing is preserved surgically and at initial activation, the hearing may not be durable regardless of the electrode length. Patients with preserved residual acoustic hearing may not use the acoustic component or don't like it. And patients with preserved hearing may not outperform those using electrical stimulation. So we're looking to measure spectral resolution early after activation, see if it predicts speech at 3 months and 12 months. Fit EAS on EAS non-users who qualify and measure speech and spectral resolution. We're doing lab-based manipulations of electric cutoff to determine how much of EAS benefit is due to poor spectral resolution in electric alone condition, and measure spectral resolutions preoperatively, look for correlations with EAS acceptance if hearing is preserved postoperatively. And Emily Spitzer, David Landsberger, and David Friedman are working on those studies. This is our cochlear implant team, and I thank you very much for the opportunity to present this talk.
Thank you, Dr. Susan. What a wonderful presentation and a totally different perspective that we heard today from you. It will be nice to discuss in this forum. And may I invite Dr. Arthur Lawrence for the next presentation?
Yes, yes, of course. Thank you. I'm going to share my screen right now. So thank you again for kind invitation and for the opportunity to share our experience with EAS. And I would like to actually start from the historical slides for historical results, and this is the indication we actually have in the 90s. We started the cochlear implant program in 1992 in Warsaw, and of course, looking into the PTA, pure tone threshold average from 125 to 155 100 hertz, we can see that these patients actually implanted in 90s, they were profound deaf, or there was even no measurable threshold. So the threshold, if measurable, were in the range of 100 dB. And in actually the beginning of 2000, at the 2000, there was a relaxation of the criteria. We learned that people with residual hearing, even if they have some benefit with hearing aids before implantation, the CI outperformed the results. So more and more people qualified for CI, they do have residual hearing. And for us, actually, the biggest change was in 2002, because Professor Skarzyński decided to implant patients with actually normal low frequency or close to normal low frequency hearing up to 500 hertz. And the hearing was preserved, and the electric stimulation in the region of deafness was combined with actually natural stimulation in the low frequency. So nowadays, these thresholds can be actually in the wide range from the almost zero in low frequencies and to the 70 dB to allow the EAS. And to qualify, to actually talk about the indication in terms of a pure tone threshold, we came up with some idea how to divide this group to do sort of a stratification. So we propose the different names when there is a residual hearing, and from the right, if there is a ES, so there are residual hearing, but electric stimulation is actually only possible because they are non-functional. We can see the EAS group, the actually classical EAS, when the threshold are usually lower than 30 dB in low frequencies, and there is deafness in high frequency, and here the amplification of low frequency is needed. But there are another two groups which are quite interesting, because there is normal hearing up to 500, and even could be up to 4,000 hertz. And we recently published on this group with very good hearing. We call this Electro natural stimulation. And if this hearing is preserved, there is no need of amplification. The patients can actually use natural low frequency hearing with their together with CI, with electric hearing from CI. And talking about the average outcome, we published this work in laryngoscope, and we actually compare the three groups. We had the two control groups, CI patients with no residual hearing, and patients with actually normal, the subject with individuals with normal hearing. And if you see that these results are the percent correct of CNC discrimination test, We did this test in quiet. So patients with no residual hearing, they on average score 67%, and patients with EAS, with partial deafness, they score 91 on average. And of course, normal hearing 100%. And for more difficult condition, like 10 dB signal to noise ratio, CI with no residual hearing on average around 30. If we see the score around 30%, the normal hearing needs actually -10 signal to noise ratio to produce the comparable results. But patients with EAS, they actually are somewhat in the middle. They need 0 dB signal to noise ratio. For the particular condition, at 10 dB signal to noise ratio, they score 78%. So they truly outperform patients with no residual hearing, comparing to their 37 on average. So we do believe that EAS can produce superior outcomes. We actually try to look into the qualification criteria based on speech discrimination, and we put this data in a different way, the speech results. Here we have a speech discrimination in quiet versus speech discrimination in noise, and the dark blue points that the individual scores in our patients before surgery. And you can see that some of them, even they can have a 70% of speech discrimination, the CNC word in quiet, but still the speech discrimination in noise can be so poor as 10% or 40%. But if we see next what is happening after the surgery, we can see that these patients benefit, and even the patients with 70% in quiet and 40% of noise, this patient actually after the hearing preservation surgery and after combination of electric acoustic stimulation, the score is almost 100 in quiet and in 100 in noise. So of course this is a star patient, but we do believe that this combination can produce superior benefit in especially in the noise, which can transfer to the better functioning in a real world. But I'm just going to show you, to share with you a two actually cases. But if we go back to this slide, because I forgot to mention that based on these results, we actually propose to have our criteria for doing CI with this hearing preservation and EAS technique. So we decided to propose 70% in quiet and 40% in noise, because when we see this example of results, all cases from when this pre-op scores are less than 70 in quiet and less than 14% in noise, they truly benefit from EAS, because they post-op scores, the pink one, they are above this criterion lines. So these two cases, one case, female 43, in a hearing gain 90% in quiet, 60% in noise, right ear 170, and both 90-60. So we decide not to do the implantation and advise to use the hearing aid. But the second, with also female, very similar audiogram, the results are much poorer, although we repeat the different trial with amplification with hearing aid, but this female actually fulfilled our criteria, and there was a decision to do the implantation because the results in quiet was less than 70% CNC words and less than 40% in noise. And also with both hearing aids, this results 50 and 20, they were in the range of our criteria we propose. And this is actually going in line with some works about damage of cochlea, about so-called information carrying capacity, that in some cases the amplification doesn't work, even if we think from the threshold that the benefit from hearing aid should be present. So after the surgery, this individual scored 90% in quiet and 70% in noise. So sort of our average, what we expect in EAS population. This female were extremely happy with outcomes. Just at the end, I'd like to actually mention about one of the special group of interest. We have a patient with single side deafness, and with actually EAS looked like audiogram in this deaf ear, so with some low frequencies, and we published the paper. Then when we look into the benefit of CI with the condition of mask and non-mask residual hearing with the implanted ear, when it was non-mask, we have a significant benefit for all effects like redundancy, squelch, and better ear effects, so head shadow effect. But if it was actually mask, only the head shadow, the better ear effect was statistically significant. So we concluded that EAS even work in this special population. Thank you very much for your attention.
Thank you, Dr. Arthur. It was a great presentation. It was a little different and contrary to what we heard by Dr. Susan. It will be really interesting to hear both of you and conclude as we are beginners about an EAS, and we have to really learn from you guys. So thank you so much. So may I invite Dr. Ranjit Rajeshwaran to start his presentation next. Thank you. Ranjit. I think he's gone somewhere. So in the meanwhile,
it's not here now. It's not here now. Yes.
Yeah, thank you. So welcome, sir. We missed you in the first little portion. So can I invite Professor, I think Ranjit has come, or shall I invite Professor Mario to start his talk in the...
No problem, please.
Thank you, sir. Thank you so much.
To Mario, I'll be sharing the screen. 1 sec.
Okay.
You're all able to see my screen?
Okay. Yes.
Yes.
Well, thank you so much for the invitation. Dear colleagues, dear Nevita, my proposal with this talk is to talk about only with the point of view as a surgeon. Okay, next one. Okay, you know that to do electroacoustic stimulation, we need to do a soft technique. The atraumatic of surgery, from my point of view, is a less traumatic surgery, because atraumatic surgery it doesn't exist. Therefore, according to my colleagues, Susan and Mohan, we can do a partial functional preservation, but we can do a very good structural preservation. Why? Because, as you know, with the time, usually in the first month after surgery, we have a very good functional preservation, around 70 to 80%, but with the pass of the time, we lost this hearing rest, and therefore we need to put the objective in a structural preservation. Next one. For do the surgery of electroacoustic stimulation, in my opinion, we need to use drugs. It's very important to choose the best approach to the inner ear. And finally, the election of the electrode is crucial from my point of view. Regarding to the first item, the use of drug, next one, you know that there is the steroids. Next one, please. The steroids are the best option to do the hearing preservation, because as you know, the dexamethasone is against the factors that produce the apoptosis. Therefore, the dexamethasone is the drug with most evidence in preserve the residual hearing. Second, the via to put the dexamethasone in the inner ear is better the local alternative intraoperatory, for example, near to the round window, is better than the intravenous alternative, because the concentration is totally different in one way to the other. And finally, the most recent investigation, you know that we have in more months the Dexel electrodes. Dexel electrodes is the dexamethasone elution electrodes that can produce a delivery of the drug of steroids inside the cochlea through the array of electrode. This is the new option to preserve the residual hearing, and it's very important to take in account. Next one. Regarding to the approach, you know that there is a lot of publication regarding or discussing if cochleostomy, round window, or extend round window. The most of papers show us that the round window or extend round window is better than cochleostomy to preservation. But, however, cochleostomy could be used with certain details, technical details, and we can preserve with cochleostomy. But if I can do the round window, only round window without extend round window, in my opinion, is the best option to preserve the residual hearing. Next one. Finally, regarding the most controversial topic is the electron. Probably we know that the short electrodes are better than the long electrodes because it's not touch the region of the apex. But on the other hand, when the patient lost this residual hearing, lost the possibility to the better pitch with the electrode. Therefore, I believe that the short and lateral wall electrodes, because are more flexible, has more evidence to preserve. However, long electrodes can preserve, as was mentioned previously, and perimodular electrodes can preserve too. Therefore, could be a good point to debate. Next one. Okay, this is the last one. My proposal with this short presentation is to invite you to a debate about the drugs. It's very clear. The approach to the inner ear, it's clear, but the topic of electro is not clear. And I believe that we as a surgeon need the opinion of the audiologist that know which is the most precise electrode to hearing preservation and, of course, to electric acoustic stimulation. Thank you very much.
Thank you, Dr. Mario. It was great to hear your views and learn from your experience. And now, can I have Ranjit here? I think Ranjit has got a power cut. There's a Chennai, there's raining, and he is completely disconnected with us. So I would request Apurva what to do. Shall I go ahead? Shall we wait for Ranjit? Because with Ranjit, we will be finishing all the presentations. And then
Nivita, I think you should just go ahead because he's having problems, that his area is flooded. He's trying to get a connection through battery connection, but it might take time. So I think you can just go ahead. He can always join later.
Okay, sir. Thank you. So that's perfect. So we finish with all the presentation. Thank you very much. It was really enlightening. Nice to hear various perspective, views from different parts of the world. And now onwards, I'll be asking, basically, I have formulated some questions for discussion. And my remit as a moderator of this World Cafe is to come to a conclusion. Hopefully we do, and come to a conclusion and present again at CGCon on 14th of November. So I may be asking very basic and simple thing, but then we have to come to conclusion because there are various views and ideas, and so we'll come there. So let's hope, and I'm looking forward to active participation from all of you. So I need to do the screen sharing, Satish. So will you allow me to do that now?
Ma'am, you can go ahead.
So 1 second. So I've done the screen sharing.
We're able to see your screen, ma'am.
Yeah.
Please go ahead.
So yeah, welcome to this World Cafe discussion panel. And it was really nice to hear all of you present and your views. So first thing, maybe very basic, but I like to know what is an appropriate definition for EAS or an hybrid implant. So mind you, you are being recorded, and I have to come to a conclusion that what is a hybrid implant or what is an EAS. So can I start with, so I'll start with one person, but I would like to have input from each one of you, and you can take it on, and so that we come to a conclusion that what exactly it is. So Dr. Arthur, can you start with this? You are muted.
Yes, of course, I can actually try to put some perspective, because in my opinion, there is a lot of confusion about what we name hybrid technology or hybrid implant. For example, I noticed that especially in perspective of Europe, the hybrid or the EAS can be in terms of short of length or electrode means completely something different. We use the long electrode like 30 millimeters, so 20 millimeters can be for us the shorter one. As I understand from the speech of Susan, in US, the hybrid means actually, or from the past, actually meant a really short electrode, like 12 millimeters. So this is one, of course, the problem how we understand even the concept of short and long electrodes. Nowadays, there are much larger, much greater choice. The electrodes, there is of course, one brand who propose the different size, different length of electrode. You're going to have 30 millimeters, 28, 26, 24, 20. When we actually really cannot use anymore the concept of what is short and what is long, because how we put the 26 or 28, if it is long or short. So for me, the concept of EAS is when we actually can prove that whatever electrode we are using, even 30 millimeters, and there is a hearing preservation, and there is a benefit of hearing through the acoustic part plus the electric part. Because another confusion is when we are thinking of EAS by only looking at the EAS processor. So EAS processor amplify low frequency, but if there is a beautiful preservation of normal low frequency, we don't need amplification. But still, patient can actually combine acoustic and electric hearing. So it is always the what we actually propose to name it a little bit different than EAS, like this electric complement or electric natural stimulation. But this is also the proof that patient can actually benefit from this combination, even if in theory we are using electric alone because we don't amplify. But why we need to amplify if the threshold is, for example, 20 dB at 500, and next is this ski sloping. So for me, the EAS is when we actually can prove with amplification or without the amplification that we can successfully combine acoustic hearing and electric hearing.
Thank you, Arthur. I would like to hear the same view, a similar thing from Dr. Susan. Can I have your views, ma'am?
Yeah, I totally agree with Arthur. I think that the term hybrid was used just as more of a generic term. Now, I think in the US, we're really not even using that term very much anymore because it's associated with a particular implant that, like I said, is not really being used here anymore. So we're starting to use EAS more. Sometimes the word hybrid will be used, but not in connection with a specific implant, just meaning a hybrid configuration of electro and acoustic stimulation. And I also agree that if there is preserved hearing, really good preserved hearing in the low frequencies, that also means an EAS configuration. You don't have to have a hearing aid there. So I think it's, for us, it's really not that confusing here. We have really defined it. We don't use the word hybrid that much anymore, except maybe to look at the nature of the hearing loss, because it was defined so much for us in that in the hybrid implant study, the clinical trial. But we are using EAS, and I totally agree with everything Arthur said.
Thank you. Can we have surgeon's view, Dr. Kameshwaran, please? So you agree with so we have to come to an agreement with all these points, and so that we can come to a conclusion on it.
Well, I always agree with audiologists. I never disagree. I think to me, in my mind, I'm sure Mario will say the same thing. It's a successful integration of electrical and acoustic hearing within the same cochlea. So that's what I, so to put it short.
Thanks for simplifying. Yeah, it's nice to. Dr. Mario, you have anything else to say on this?
No, I agree that the most important is the type of stimulation, electric or acoustic. Therefore, I agree with the term electroacoustic stimulation.
Thank you. Thank you. So we move forward with this. So candidacy. Are we only looking at adults, or have we started thinking for children as well? Because so that's one area that we need to know. And then I'll be asking. So we all agree that it's only for adults,
No,
the candidates? We are
No,
not looking.
we do it on
No, no.
children as well. We do it on children as well.
Okay.
So it's not only for adults here.
So can we have your views on children? So you are doing, and so what are the criteria? Because I took up some of the criteria and it says 18 years of age or older. So what is the pediatric criteria for EAS?
Just their hearing, you know, really for us in the US, just their hearing. You know, the FDA can set certain guidelines, but they're not the law. So while it may be labeled, what you're looking at maybe is some hybrid, again, the old hybrid criteria. We can do really anything we want with the devices, especially using the longer electrodes now. We don't have many children with that configuration, but when we do, we don't hesitate to implant them. And we have several children using an EAS configuration with a longer electrode.
Okay, so may I?
Sorry.
Yes.
My only concern is that in children, we have the possibility of hearing deterioration with the time more than the adults. It's the only concern, but I fully agree that it's for children and for adults.
Okay, so it is for both. And so these are some of the audiometric criteria.
but maybe I just put one comment and actually just follow what Susan actually already said, because this is the answer of the concern. If we can have longer electrode with the hearing preservation, this problem of hearing deterioration is not so severe problem, because the most important issue is the decent, it's enough cochlear coverage. So if with the enough cochlear coverage we are successful with hearing preservation, of course we can use this beautiful concept in children. Our first children was implanted in 2004, and in time we do see some progress. We can change the amplification of acoustic part, and in worst scenario we can reprogram the electric part with the when there is a loss of acoustic hearing. But still the most now I think important is that in children we should consider just longer electrode.
Thank you, Dr. Lauren. May I know what is the minimum age that you're looking at children for EAS, or is there any criteria, or are they good enough to undergo speech discrimination scores and then you select, or you select only based on audiometric thresholds? So may I have your comments, Dr. Arthur?
About the edge, of course, usually our patients with a good low frequency hearing, they receive this CI later than we are now thinking about children with profound hearing loss. Usually we see them around that in our material, they are older than 4 years, and very typically they are implanted even at between 6 and 8, because so before they can actually develop quite well using acoustic solutions like hearing aid, and next they observe some delay. So usually the CI is this EAS with a good low frequency hearing in this group, EC or ENS is higher. They are all a little bit older than regular CI cases.
So
I'd like to make a comment on what you've got up on the screen now. I think what you have up on the screen now is the labeling literally for the hybrid device and what was a clinical trial. And I think it really, that's
Okay.
from 2013 or 2014. It doesn't really apply now. We've really moved on from the official, the cochlear hybrid device, and from what was the inclusion criteria for that clinical trial. So it doesn't really apply now.
Okay, so it has changed quite a lot. Thank you for your input. So basically, and it has expanded further, right? So that's what we are concluding, and it is going on to children as well, but little older children. Am I right here? Yes.
Yeah, usually yes, because in they are very young, they can develop using acoustic hearing.
Acoustic.
Nimita, can I just say something now?
Yes, yes.
So I think, I need to put the surgeon's perspective. You see, the important thing, I think, is that, you don't do hearing preservation surgery in people who only have hearing worth preserving. That's the first thing. So what I mean is that you need to be doing hearing preservation surgery in everyone. That's the only way that your center is going to have the confidence to preserve hearing when it really actually comes to the case that needs to be preserved. Now, what I'm trying to say is, if you're doing, let's say, 100 implants a year, and about 4 of them actually have hearing worth preserving, but all the other 96 also should have soft surgery, hearing preservation surgery. So only then can the team have the expertise to do in these 4 who really matter. When you start doing that in children, you'll be quite surprised to see that a lot of children may not have great hearing to start with, but that whatever hearing they have, you're able to preserve as your experience grows. So you actually can preserve hearing in children, even with the standard electrodes, long electrodes. But no doubt, when you have the special electrodes that are soft and long, the chances are much, much better for preserving hearing. Now, having said that, there's also no doubt that when you do in children, the chances that they're going to need or going to convert from electroacoustic to purely electric stimulation at some point of time is very, very high. As they follow them up, as Susan showed in her presentation too, a lot of them would prefer to have electrical hearing alone now after some time, even if they started with electrical acoustic hearing. So one has to always have this possibility in mind that this child would at some stage, even if it started with electroacoustic hearing, would become purely electrical at some point of time. So we have to give allowance for that, which means that your question of having short electrodes is out right from day one. So you're going to be having long electrodes. How long, you can debate about it, but certainly long enough to give a complete cochlear coverage at some point of time. So basically, you're looking at preserving hearing in everyone, whether they have hearing worth preserving or not. And some of them would have hearing worth preserving, may not be great, but would still have hearing worth preserving. But they may, as time goes, convert to purely electrical stimulation. And you may have later changed to electrical from electroacoustic. So I think this is the point. And as time goes, you are likely to lose more and more residual hearing in these people, whether it's due to the natural progression of the disease, or whether in some way our electrical stimulation itself has a bearing on the subsequent events within the cochlea. We don't know. Even now we have no idea about it. But one suspects that the very fact that you've got a foreign body in the cochlea itself is a reason enough to induce a chronic inflammatory response inside the cochlea. And this may have some, deleterious effects on the very fine microstructure of the cochlea with time. So we all know about the fibrosis which happens around the electrode. We can always see that in your, explanting and reimplanting, and how this fibrosis develops over time. We have no idea. We know that it can be progressive. So to cut a long story short, I think the important thing is, even when you have electroacoustic hearing and you have acoustic hearing, which is significantly worth preserving, the good surgeon always makes allowances that over time, it may lose that acoustic hearing, even if not within the first year, maybe over the next 4 or 5 years, and you may have to resort to electrical stimulation at some point of time. But whatever you can preserve, and the longer you can maintain the acoustic hearing in that particular child, I think the more beneficial it is for the recipient.
So, okay. We should not have any minimum criteria as such. At least any loss in the high frequency, mid and high frequency can be going for implant, can be a candidate for EAS stimulation. So I'm skipping this, any difference in candidacy on cochlear, middle and AB, because we all agree that there should be a uniform candidacy with any residual hearing that should be preserved, and they are potentially going to get benefit with the EAS stimulation. So I move on with candidacy. Any exclusion criteria, sir, if you think of, or is it same as standard cochlear implant?
Yeah, I think to me, I enlisted a few. Wherever you are sure that there's going to be definite progression of hearing loss. Let's say, for example, meningitis, post-meningitic patient. You might see a post-meningitic patient with good residual hearing, but chances are very, very soon this residual hearing is going to go, because we all know that post-meningitic sequelae leads to significant and fairly dense fibrosis and then ossification of the cochlea. So I have seen ossification develop, complete ossification in the cochlea develop within just 15 days. So, things like that can happen. So you know that this patient will progress. So therefore, that's a patient in whom, rather than worry about preservation of hearing, depending on acoustic hearing, you would tend to make allowance for electrical hearing sooner rather than later. So progressive disease, I think, is the, progression of the disease is probably the biggest contraindication.
Yes, sir. Anyone else for any other exclusion criteria apart from what is standard for cochlear implants?
I just would add that, of course, if we are using the fairly long electrode and still we can preserve hearing, I believe that even if we are sure that there is a progression, as actually Professor Kameswaran mentioned, we as audiologists, we can even for a couple of years give the child better possibility to hear by apply the EAS strategy. We have a lot of evidences that if there is especially the acoustic hearing from both sides, the child will have a better discrimination in the noise surroundings. So for child, even at this same beginning, it can be really beneficial to have a better access to language, to spoken language, even in a difficult situation. So I would advise to try at least with feeding of EAS, even if it is in a couple of years, we probably will have or would have the hearing deterioration.
So as long as we can use the residual hearing is what is recommended. So probably the exclusion criteria is same as what is there for average cochlear implants. So thank you. So we move next. So why EAS or hybrid? How So this is mostly audiological question, how it affects the sound perception in terms of amplitude, envelope, or fine structures, temporal structure of sound, low frequency acoustic stimulation. Does it promote better pitch or tonal recognition, quality of sound, localization, speech recognition and noise, prosody recognition, music appreciation and aptitude, and preservation of cochlear structures to capitalize future advancements of the inner ear. So yeah, sorry. So can I have Dr. Susan or Arthur? Ranjit is not here, unfortunately. So I think Arthur, you have to start with this.
Okay. Yes, of course, there is a lot of evidences that preserved low frequency hearing can have a better access to fine structure of the signal and also have a better frequency resolution and can actually facilitate the perception of fundamental frequency F0 and can actually help with both, actually three things, the speech discrimination in noise localization, if there is low frequency from both sides, because usually this is the case. If there is even not bilateral EAS in the opposite ear, the opposite ear is usually the same or even better with hearing aid perhaps. So there is an access to fine structure of the signal in low frequency from both sides. So definitely it can help in localization, but also, as we actually demonstrated in our last paper, it can facilitate the unmasking, spatial unmasking. So all these binaural effects like better speech discrimination when there is a segregation from sources, when there is spatial segregation from speech and noise source.
So you agree, all of you, like it does affect, it does help
Yes.
in better speech understanding, in better, what about the pitch and tonal recognition? Does it has a role to play in that prosody and quality of speech?
If we are talking of low frequency and preserve the frequency resolution, because of course there is another issue if the preserved hearing has a good quality, because of course it could have not enough frequency resolution, but if there is a preservation of other characteristic of hearing, like frequency resolution, there is a better access to fundamental frequency of the voice. So definitely tonal recognition is improved.
So music perception is better with
music,
EAS.
and definitely music perception.
And also speech recognition in noise because of the fine structures and localization of the sounds is better. So basically speech recognition and noise better. So
I can recall two patients, in whom we had preserved hearing and had electroacoustic stimulation. Both of them were very musical. One was a music teacher, and the other was a youngster who was playing in a band. I think both of them really appreciated, the difference. So they were very, very happy. They could continue their work. One of the biggest problems you see in adults after cochlear implantation who had music experiences, they had no residual hearing. They loathe the sound that they hear, in music. As people who have been very musical before, who have lost hearing. If you give them cochlear implants and then they're no matter what the company says, it's not the same thing. They're very, very unhappy. But when you preserve a bit of acoustic hearing, as Arthur said, it makes a whole lot of difference. Their experience is so much richer, and they feel so much, better and able to appreciate music. And the difference is glaring, I think, in particularly in music appreciation.
thank you, sir. Even I feel so, but Dr. Susan, maybe, are you there, ma'am? Because
Yes.
you,
Yes.
you had a different view. So it will be nice to hear from you that some of your patients and case studies you showed that did not appreciate EAS. So it would be really interesting to hear your point of view and what your patients perceived.
I think the path that we're taking here is that we need to study this a little bit more. We really don't know. All we have are reports from the patients. And a lot of them, from our standpoint, they didn't find a difference. Some of them it could be more that they just wanted to use the off-the-ear processor. But I think we need to study this a little bit more. We need to know what the cutoff frequencies are. We really don't know in general what they're hearing, where they're going to do better. Some of them were close to that 75 dB mark, and they didn't like it. So I think from our standpoint, we need to study this more. We haven't seen any absolute definitive conclusions that we can make about how this is really helping a lot of the patients. And I think by studying it more, by looking at the spectral analysis and so on, we may get more information about it. We haven't seen that music appreciation and aptitude in our EAS patients. But again, I do think it has to be, it really depends, one, on the level of hearing. So what we're planning on doing is studying it at each level of residual hearing and seeing what we get. Now, localization is an interesting one. We haven't noticed an improvement in localization. It depends more on the non-implanted ear. So some people also define EAS as having the implant in one ear and the hearing aid in the opposite ear. Again, it all depends on the level of hearing. So I think that we really, I have to reserve judgment as far as personally, as far as I'm concerned, as to what the actual benefits are and which patients get these benefits and at which level of hearing they can maximize the potential of the EAS configuration.
So maybe can we just conclude that if we can divide the categories of these patients with some good residual hearing post-implantation and one with a poor residual hearing post-implantation, maybe those are not liking EAS and not getting potential benefit, and the one which has some residual hearing better after surgery in a long-term basis, maybe they are appreciating these efforts. So can we conclude that, or we just leave it there?
No, not for some of our patients. On the one slide I showed you, the patients who really didn't have any hearing liked EAS, and the patients with an EAS with a lot of residual hearing didn't like it. So I don't know, I think I appreciate that you're trying to have conclusions on everything, but I don't really think we have all of the answers yet to really make sweeping conclusions. I think some patients will and some patients won't right now. And I think we need to study it a little bit more to know.
Okay. So this is a gray area. We'll leave
Nivita,
it. Yes, sir.
Nivita, this is Ranjit. I'm extremely sorry.
Ranjit, welcome back. Yes.
And I'm using my mobile phone, so there was no power. So I was just requested.
Thanks for coming. It's really nice.
I'm so sorry there was no power cut out this rain. But I have a different view on this particular thing, because what we don't have much patients with EAS. We only have some 8 or 10 patients there. But what we have done is we looked at the psychoacoustic studies on these patients. So we looked at the DLTs, DLIs, and also the GDT, the gap detection test, on the electric and the acoustic component of it. Okay. Now, all the psychoacoustic tests that we did on the acoustic component, that is at the low frequencies where the residual hearing is preserved to some extent, okay, these are quite a variable results. Now, a patient with a good residual hearing preserved, they showed the DLT, DLI, and DLF, which is very similar to the normal hearing subjects in those frequencies. So the patients with poor residual hearing showed a little deviated results compared to the normal hearing subject. So I think the amount of the residual hearing that is, preserved matters a lot in music perception as well as in terms of localization. As Susan said, I agree to it most of the thing, and it all depends on the contralateral side and what kind of device they use actually. But another interesting thing, I think Arthur also quoted, we looked at the binaural masking level differences in a patient with bilateral EAS. I mean, yes, for one patient, we could do the binaural unmasking. So which means that, some of the fine structural cues on phase locking and unlocking of thing was present in this. But we did not find it in all the patients. So there's also some amount of etiology that plays a major role apart from the decibel values that you preserve it as, you call it as the residual hearing. So that is one point. Another interesting thing that what we looked at is when we started training these patients very rigorously on minimal pairs and fine discrimination tasks with that, I think the scores improved. So again, what kind of training are we going to provide to these patients? Most of them are postlinguals, but the kind of training what we give, so give them an intensive listening task, give them very minimal pairs, very minimal differences between two frequencies, a refined discrimination auditory training, and we could also see some improvement in that. So I wouldn't completely put everything on the amount of residual hearing. Of course, though it matters a lot, but the training also matters a lot, because we really have to discuss something on how do we train on these patients with EAS, because they come with different etiologies as well.
No, thank you, Ranjit, for your insight. So as Dr. Susan also agreed that we need to investigate further. So that means we need to assess these patients for various tests and investigation. And also every brain responds differently to different input of sound. So we need to study there also. There's lots of, so yeah, so thank you so much for your input. We move further. We have discussed this. So now coming back to our surgeons in the panel. So we have discussed this. I think we have almost concluded that what factors that matters: length and type of electrode array, insertion, round window, extended round window, antero-inferior cochleostomy. So Professor Mario, if you are there, so you can start with this.
Mario had to leave, actually. He sent a message to me.
Sir, you have to do this.
Yes, I'm the sole surgeon here now. Yeah, well, I think we already discussed about the length and the type of electrode array. There's no doubt that you want soft electrodes, specially designed soft electrodes. And the length, yes, it's always a compromise, the compromise between a short and a long electrode. Long is what you would like for long-term, electrode usage. The short has probably got a better chance of preserving whatever residual hearing is there, but it's always a compromise. I think with the advent of better, slimmer, soft electrodes, we are now daring to use longer and longer electrodes than when we started. So that's I think the way it's going now. So long, slim electrodes will probably be with us for some time. The round window is what we prefer. And the reason for the round window preference is, of course, that you have this ready-made, structure, which can be used for a very soft penetration. But there are some issues with the round window, and the round window issue really is that your electrode is, when you're inserting through the round window, there is going to be a kink in the electrode. It's going to change its direction. It goes and hits the promontory. It hits the modulus and then changes direction, and that's unpredictable. So generally, that's the one factor that you have to keep in mind when you're inserting. But I think with increased experience, the surgeon can literally feel the electrode going into the cochlea. You can see the migration electrode inside the cochlea. You can actually feel it with his tactile sensation. So you can direct it. But the big advantage is that you know that you're in the right scala to start with, and you're in the right place. So round window is what most surgeons, I think, would prefer in hearing preservation. As I said, the idea is to have a very small incision in the round window membrane, usually the anteroinferior quadrant, and direct your electrode away from the modulus. That way your chances of kinking are much less. And the important thing is the duration that you take for insertion. It has to be very, very slow. A lot of people have preferred robotic surgery for this particular step for insertion, because unlike humans, robots can be very patient, so they can go in at a very predetermined slow pace of insertion. And the idea why you want to have a very slow insertion is that you want to give time for the hydrostatic compensation of the cochlea. In other words, the fluid inside the cochlea, when you're putting a piece of metal inside, suddenly there's an increase in the intracochlear pressure. And this has to be compensated by fluid coming out through the incision that you've made. So therefore, if there's no sudden increase in the pressure, because if there is a sudden increase inside the cochlea, the pressure, then it will rupture the membrane. So you need to go very, very slow in your insertion technique. And once you've done that, then, of course, now with the intraoperative ECOG monitoring, I think you have a much better chance of doing that.
Yes.
And then you can, of course, plug the incision at the end of the procedure. So I think we are getting better tools like intraoperative real-time electrocardiography. You've got robotic insertion techniques. All these are going to help in hearing preservation surgery in the future.
Thank you, sir. And use of steroids, I read somewhere that
it's mandatory. I think it's only a question of, as Mario said, it's a question of the route of application. So some of us give intravenous, steroids, and also local steroids. There are others who do not give intravenous steroids, who just flood the cochlea with steroids, and then through the steroid lake, as it were, do the insertion inside the round window. So both are fine. I think you have some doing this, some doing that. I don't think there's any clear advantage either, but there's no doubt that steroids are very, very important in hearing preservation.
And insertion depth, that like the length and the depth are very.
Yes, absolutely. Yeah, and the angle of insertion also.
Angle of insertion is coming, and wrapping factor and intra-op monitoring. So we discussed intra-op monitoring, and would you like to comment on angle of insertion, sir?
Yes. The angle of insertion, as I said already, it has to be in a certain direction. Generally, we like to do it the anteroinferior direction, away from the modulus. So this angle of insertion has to be very, specific. And as it turns the basal turn, you have to give allowance for the fact that it will hitch against the lateral wall and then change direction. So you need to be very, very, very soft there, to allow for this change of direction. So you don't want to traumatize the lateral wall of the basal turn. So I think these are the factors to keep in mind. Of course, you have no control over the electrode once it enters into the scala. All that you can do is direct the, reduce the stress on the electrode, and thereby reduce the stress in the cochlea.
Thank you, sir. So basically, we know it matters. And what percentage of hearing preservation are we talking about? And does it change the outcome? And
I think Nimita, before we go into that, we need to know what you would consider as hearing, as having preserved hearing. When you say somebody, I've done surgery and I preserved hearing, what does it mean? See, different people use different standards. And it is very important we have some kind of uniformity there. Of course, I leave it to the audiologist, but we surgeons generally, if I say I have preserved surgery, then in surgery I preserved hearing. What I mean is that my post-operative audiometry is not going to show more than a 10 dB shift, from pre-operative audiometry. If it is more than that, I may have good residual hearing even in spite of that. But if I have shifted more than 10 dB, then to me it's not preserved hearing. I have lost hearing. So when you say I have preserved hearing, it's a very specific term. You should not have more than 10 dB shift from a pre-op to post-operative level. If let's say we start with 30 dB, hearing, and I have post-operatively, I have something like 50 dB hearing. It still has good hearing, I might benefit very much from the acoustic hearing, but it's not really classic preservation of hearing. So we need to have certain specific, guidelines about it.
Any more input on this hearing? What exactly we mean by hearing preservation, as sir started it very rightly. So can we have more views on it?
I want to know what the audiologists think about it.
Yeah, Dr. Susan.
Yeah, I think that what we're starting to look at now, it's not just the level of hearing. We need to know what the quality of this hearing is, what it brings, what the differences are between the end result levels of the hearing. I think, and there are also degrees of hearing preservation. Like you said, you don't want to see more than 10 dB. Well, 10 dB, from what I know from clinical audiologists, they tell me that could be a testing error from pre-op to post-op. So I think what we're trying to do with prospective studies is to look at what does this preserved hearing really mean, and at different levels, what are the benefits at each level? And I think maybe that will tell us more about what the quality of this preserved hearing is. We don't really categorize preserved hearing as yes or no. We say hearing maybe was preserved within 30 dB. There are different levels of preservation, basically. But I think, again, we need to study this more and say what it means. So we do not have a percentage of hearing preservation that we consider. It's also not just the threshold levels.
Okay. So you are looking at degree of preservation?
We're looking at degree of preservation to see how perhaps the results differ with that. We're doing a study both on adults and children to look at this. Does it change the outcome? That's what we're looking at. I don't think we can really answer those questions now. I think the N is really too small from our standpoint. So we're just going to wait and see what our upcoming studies show. And as far as what happens to hearing preservation with time, I think we showed that over a lot of these people lose more hearing over a period of time. And that's what makes these longer electrodes very attractive, because we don't then have to reimplant, and these patients can still do well. It depends on, I think, I don't recall who said it, but it also depends on etiology. Sometimes you know that a child or an adult is going to continue to lose hearing over time.
The progressive losses ones. Yeah.
Exactly, both in children and adults. But you don't really know, is it the etiology? Is it the electrode being the placement? It could be a lot of things. So I think we're going to reserve judgment on what the outcomes are until we see what it is at each level with different etiologies.
Yeah, so, okay. So just a thought, food for thought. I thought it will be a nice point for discussion, because we all looking at differently the same thing. So maybe we can try and come. I know it's hard to conclude, but then at least some clarity after discussion.
Nivita?
Yes.
Just a small thing, I completely agree with Susan, because it's just not the values, it's the quality. So what we have done is a small pilot with 2 of our patients. We're trying to mask the residual hearing. So you create a low frequency noise using your MATLAB, just mask it and measure the speech perception score only with electrical, and then just stop the masking and see if we're trying to see if it can make some difference and what level of difference with what different level of noise, then will that give us some indication of the percentage of residual hearing in terms of the quality of perception of speech. So we've just started it using a MATLAB design. So we've just running on 1 or 2 subjects on that, but it's too early to tell what our results are, but we just given a try. So which means primarily we're looking at, just eliminating the preserved acoustic component and present only the electrical stimulus. And then also provide the acoustic and electrical if the perception is better in some way or the other, and how much depending on the noise level. So that would help us to see what's the quality of hearing is preserved with acoustic and electric together.
Okay. No, that's a good input, Ranjit. Thank you. So we move.
That's just one more comment, because I think that also the preservation in terms of a threshold usually for surgeon is a marker of a traumatic electrode. We just assume that if there is a complete preservation, there was no trauma. If there is some drop in hearing, there is a trauma. So looking at the threshold is also important for surgeon as a marker of how soft they are into the cochlea. That's why as audiologists, we work on this classification system of hearing preservation, because I obviously agree with Professor Kameswaran that we can use different definition what we understand of hearing preservation. When we are losing 30 dB, for example, and the patient start with 0 dB at 500, still we have a lot of hearing to combine with. When we started with 80 dB and patient is losing the same 30 dB, actually we are losing almost everything. So we propose a classification system based on actually sort of a percentage of auditory field we can preserve, and this was published under the as a multi-center actually guidelines from hearing. It is called the hearing preservation classification system, and I think that this can actually, if used, and it is quite wide use because we have a lot of citation from this paper. So I think that this system can actually help to communicate better and compare results between centers.
Now, basically, we need to be more structured in terms of defining hearing preservation. Yeah. Thank you.
It is so-called Skarzinski classification system, but this was actually paper from a lot of authors, and there was an effort to actually define what we name and how we measure exactly hearing preservation.
No, thank you for your input. So moving further, in interest of time as well, what industry has to offer us as of now? So long versus short, short versus long. I think we are more or less clear that we need to have long electrode array and not the short one is like lateral versus perimodular electrode array. Sir, Dr. Mohan, like I would like to have your opinion on this, like lateral versus perimodular, which is more likely to.
I think the ideally you need to have neither lateral nor perimodular. You need to have a mid-scalar electrode. That will be the best. But if you're going to choose between the two, I think preservation is probably better with the lateral rather than perimodular.
So lateral wall.
Yeah, perimodular, you tend to be a little more aggressive in your insertion, and the question of very slow, deliberate insertion doesn't arise with perimodular electrodes.
I think some of the surgeons in the US would probably not agree with that.
No.
And feel that the perimodular electrode array could give you equal preservation. And there have been a lot of obviously published articles on this. And I think both really can preserve hearing. It depends really somewhat on a surgeon preference and what the individual surgeon is most comfortable doing and most skilled at doing.
Yeah, true. But the problem with the perimodular, Susan, is that you have, when you're inserting, the insertion time, is probably not as well controlled as with a lateral electrode. But I agree with you. It's a surgeon preference. There's no doubt about that.
We have some of the perimodular slim electrode array, and they are some of the published data is showing some hearing preservation with that. Anyway, so basically we can have either, and it is based on surgeons to choose that. And I think all the companies are offering atraumatic electrode array for hearing preservation. So how many of us are having this access of intra-op monitoring cochlear potentials? Because this is quite, is it readily available for clinics to use? And what about drug emitting electrode array? So these are
yeah, I think the intraoperative Ranjit can talk about it, because he's been doing for us. It was very helpful. There's no doubt about it.
Yeah, Nivita, that's precisely what my presentation is about. A few slides intra-op. Okay, now what we use is we use the intracochlear electrocochleography. So most of the, all the patients who underwent EAS or MEDAL users. So the MEDAL has this facility, the option in that. And it is quite useful. But the only situation where I really have my double thoughts while I was using it is when you keep moving closer, when you're recording electrode, which is nothing but the electrode 1 of your electrode array. So when you keep moving closer to the apical region, the amplitude of the ECOG G increases. Okay, at some point the amplitude goes down. So the question is whether are we crossing that boundary, the cutoff boundary, or is it something electrode translocation, or there's some damage that's causing to the intracochlear structures that is reducing the amplitude. That's one thing which we really need to investigate much more in detail. But apart from that, the intracochlear electrocochleography has been quite useful, at least to tell or guide our surgeon, at what level to stop, or from what point of time the insertion has to be even more slower. Right? When you're moving much closer, and if you see the amplitude going up a little bit, then we tell the surgeon, the amplitude is increasing now, you need to be a little more slower on that. So these are the two important informations that we would get with that. But of course, sorry.
Yeah, go ahead. Sorry. Yeah.
We also have a way of measuring the post-operative intracochlear electrocochleography. So where you can use the same electrode, which has already been inside, and then we now have we have just started recording it. I don't have any much data on that. Now we have a separate stimulator, so which can stimulate the low frequency, the preserved area of the cochlea. And then you can still record the electrocochleography. So we are trying to use this one to monitor the preserved residual hearing. So one way is we are looking at the behavioral test. You put a psychoacoustic test, you give a stimuli to appear on audiometry where the patient responds. Another one is you can also measure the objectively the preserved residual hearing. So these are, but it looks like quite promising, but we need more data to come at much more in detail in it. So as of now, the number of subjects what we have is very minimal to give any clear-cut indications and these and the applications of it.
If I can add something, Nivita, just add a bit. I think this is very important. If you're really serious about hearing preservation. Because the surgeon has absolutely no information once he enters the cochlea. It's blind from that point onwards. And the only information that we get, if at all, is this real-time, intraoperative cochleography. That's the only, source of information inside there once the electrode gets into the cochlea that the surgeon gets. So it's an important feedback for the surgeon. So I think, it's really worth pursuing this in every center which is serious about hearing preservation. It's something which I think is absolutely, I would even say, mandatory. It's essential in the future if you're going to be serious about hearing preservation. So this is something which I think every center has to be looking into seriously.
Well, thanks. That's quite a strong
question.
recommendation. Yes, Ranjit.
Nivita, just one thing to add on to all the panelists over there. Is there a possibility, or is something that any of the centers where they also use the dynamic imaging, where as we insert the electrode, you can see the electrode progression in the cochlea, simultaneously measuring?
Yeah, Ranjit, the thing is, you can have imaging, of the electrode getting into the cochlea. For example, we have, facilities for, CT scan monitoring intraoperatively, but you cannot say whether it is just an interscalar transgression of the electrode by a CT scan. All you can say is it's progressing. There's no fold over. There's no, hitch against, or it's not buckling and things like that. But you don't know if it's crossing the scala. That can't be given by the CT, no matter how good your CT is. So I think the problem really is that, you're talking about ultrastructure inside the cochlea, which is not still, within the purview of imaging. All that you can say is you can see the progression of the electrode is smooth, it's not buckling, it's not hitching against the wall, it's not doing this, it's not doing. But you don't know if it's crossing the basilar membrane and going from one scala to the other. That you can't say with the imaging techniques we have.
The functionality aspect cannot be.
Absolutely, and that's where your intraoperative will be more useful to us.
Thank you, sir. I'll move forward. So basically, to conclude, these are the electrode arrays which can be considered as offering EAS stimulation. Everybody agrees with it. I would remove L24 because it is anyway not available to, and apart from that, I think CI512 is not, or CI532 is the one which is recommended, I think, and 522, and MEDEL and high focus ultra mid scala is, or slim 1J, both they say that it has a hearing preservation capability. And the angle of insertion was 360-degree insertion through the provide electrical hearing from 1000 Hertz and beyond to reduce low frequency hearing loss. So what is the right angle of insertion? Maybe 420 or 360. They say lower the angle, the better the hearing preservation. So can we have a little discussion around this point? And then
I think I'll agree with Susan here. I think we need more data. I think we need more time, and we need to see a lot more data coming back from these electrodes before we, come to some definite conclusion. I think it's still evolving, and Susan is quite right in saying that these are early days. So we need to have more information. But 360 degrees seems to be, the bare minimum. I think that's what we're all talking about, and perhaps 420 may turn out to be good, often in the future. But we need many more cases of hearing preservation and more data. And let's face it, you don't have too many of these cases around. Very few. So you really need to pull in a lot of data from different centers before you can come to conclusion.
I agree, sir. I agree. So I'll move forward. So sound processors, Ranjit, you can say that we have in all three companies, we have the sound processor to offer EAS. Is there any difference between the three companies that they have in terms of sound processors? Like, can I have some comment around there?
Pretty much, more than the sound processors, they have different sound coding strategies. And apart from the only thing that I would recollect is because we don't have any experience with hybrid. We never used a cochlear hybrid, the sound processors. We only had duet processor using it. But I really don't see any major difference except for some of the obvious reasons, like the directionality of the microphones and the coding strategies. I don't see anything which is different. But the point the most interesting question here is, how do we, ascertain the cutoff frequency? And that's the most important question. And frequency, how do we manipulate the frequency allocation table on that? But that is something which is interesting to know.
So Ranjit, like some of the duet processors have the receivers inside and they have only the mold that fits in the processor, whereas Cochlea and Advanced Bionic have receivers in the canal. So Dr. Arthur, would you like to comment on this aspect of different processors available in the industry for EAS?
Yes, we have actually experience with all of them. And of course, there are some differences, but I agree that all of them can be actually used successfully to feed EAS. Some patients have some obvious preferences. There are, as you mentioned, differences in ear molds and how it is accomplished. But basically, we can say that all of them can be used for this purpose.
Thank you. So there's not much of a difference and all is serving the purpose. So yeah, thank you so much. So fitting or programming, are they all integrated or are we using different softwares to fit EAS? Again, Ranjit and Dr. Susan and Arthur, I think you can comment and opine on the 3 different companies that are offering EAS devices. So are they integrated softwares?
No, we don't have any integrated software. Each company has its own software. They are not integrated and they are not interchangeable.
Susan, but I think that the question is about integration of acoustic and electric in one software.
Oh yeah,
the fitting of acoustic in one software. So all 3 are offering that. Or I should say, I should rephrase, is the common platform to fit electrical and acoustic. So are we getting a common platform or are we choosing different fitting softwares?
I'm not sure I understand that question. I mean, I think from what I understand, and I'm not a clinician, but from what I understand, there is a software package and that is used to program these devices. Arthur, maybe you can answer that.
Absolutely. Absolutely, it is like you said, that there is software that can be used for acoustic part and for the electric part. So this, I understand this question that we can use one software to actually feed both parts of EAS processor, and this is true for all systems now.
All the system. Thank you so much. So
Nivita,
what method, the programming method do you recommend? Yes, Ranjit.
I just want to add on to what Arthur said. The Maestro also has the now an thing for anatomy based fitting, because they recommend the auto plan, which will help you to choose the electrode, and you can incorporate the data of the auto plan guide you some aspect.
Okay, so auto plan can be helpful in guiding and programming of EAS devices. So
auto plan
that's
is now
informative.
Now auto plan is integrated into Maestro, the data you can with the fit.
Okay. Oh, that's even better, isn't it? That's even better. So that's really exciting. Any preference on programming method by our experts for the meet approach or overlap approach or gap approach? What I understand between the 3 approaches is like acoustic, electrical, meeting between the 3. So what approach do you follow and what do you recommend?
I am actually, we actually did quite a lot of research on these 3 approaches, and we concluded that actually overlap approach is possible almost in all cases if there is enough electrode inserted. So there is, of course, the question about what we overlap, frequency or place of stimulation, because if there is deep electrode insertion, we can have both overlap in terms of a place of stimulation and frequency, and this can be tolerated by patient. And for some reason, I really like this approach, because if there is a progression with hearing loss, I don't need to change the allocation on filters. And if patients used one allocation for 10 years, and I need to shift the cutoff frequency from 1000 to 100, it is very difficult here. There is a lot of time to adopt the brain to this change in frequency allocation of the filters. So for me, the overlap in cases with sufficient deep electrode is what we actually prefer to use.
Thank you, Dr. Arthur. I think that was very helpful. Any difference? I think overlap approach, because we all are looking at longer electrode array, and rightly so. If we frequency, then it can be hard perception in the long run. We should go for overlap approach. So just thoughts from my end, any other thoughts that you think can be adding to programming system? And overlap is again, and is not possible for short electrode. And anyway, we are moving ahead with short electrode to longer electrode. So overlap can be. And what outcome measures are we? Do we have a standardized outcome measure for looking at these patients with EAS? And what is the frequency that we should be looking at? And these are lots of questions that we discussed. Points we did discuss during the. I can see Apurva coming and is hinting the time is up, so I can rush through it. But
yeah, I hate
lots
to interrupt, but yeah, it's a fabulous discussion happening. I mean, you can take a few more minutes if you want to wrap it up, but I just want to remind you that it's about 2 hours now.
Yeah, no, thank you so much. So any additional points, like I'll just close it with this. Any additional point or anything that we missed could not be covered, and we have experts sitting here, so we'd like to hear from them.
Yeah, just the one thing that I said already, that is, every surgery has to be a hearing preservation surgery, whether the hearing is worth preserving or not. I think that's the take-home message for surgeons. They can't suddenly change the technique for hearing preservation surgery in one patient. So they have to assume that every patient has some residual hearing, and they have to train from the first day to preserve the ultrastructure of the cochlea. Gone are the days, like Rambo, we used to push an electrode into the cochlea. We have to now respect the ultrastructure, and every surgeon has to be trained in soft surgery from the first day. So that's the message for the surgeons.
Well, thank you. So yes, so we consider that every patient has hearing or structural preservation that we should be targeting at, and as much as we can do. And there are lots of areas which are gray, and we need to study more deeper and understand deeper on this topic. So thank you so much. With this, I would like to experienced audiologist much.
Okay, thank you, Nivita, and all the esteemed panelists. I think it was a fabulous brainstorming session on EAS. I'm sure the gist that would come out in the form of the presentation, which probably Nivita will be presenting on the 14th of November. I'm sure all of us will be looking forward to get that concise, clear messages, that we would have more clarity on how to take things forward. And this consensus guidelines would also be shared with the fraternity over time, and with relevant literature we can also look at getting this published within the next month to 2 months so that it can help a wider range of teams across different populations. And EAS becoming the kind of an option pretty much every other clinics would be getting into, and will be looking at implanting more of these kind of devices. Like Dr. Mohan also rightly said, the surgeons also would be looking at making this the norm way of doing the surgery. I think that will be great insights and viewpoints through this fabulous brainstorming session. And again, from the scientific committee and the organizing team, I like to thank the moderator and all the panelists for their time, the contribution, and so much science together. Thank you very much. With that, we bring this World Cafe on EAS to a close. Thank you again. Thank you, everyone.
Thank you.
Thank you.
Thank you. Bye-bye.
Bye.
Thank you. Bye-bye.
Thank you, sir.
Thank you.